Good day. I'm Lieutenant Commander Lee Wright from CDC's Division of Oral Health, and I'm excited to be meeting with you today as the Acting National Fluoridation Engineer. I'm grateful to you for a few moments to talk about community water fluoridation, and I appreciate all that you are doing to help improve the oral health of the people of Connecticut. We'll begin by looking at the history of community water fluoridation here in the United States. I want to start by getting everyone on the same page with where we've come from in our battle against cavities and poor oral health. This is a relatively new phenomenon. Just short of 90 years ago, things were very different from what we experience now. Since we didn't systematically collect information on cavities at that time, most of our information comes from the military, since they were the only national group able to record data like that. So in the 1940s, 10% of those drafted for World War II had to be turned away because they didn't have 6 teeth that touched. Just under half of those that showed up after being drafted had a dental emergency. They needed one or more teeth pulled. Maybe they had an abscess, they needed a filling, etc. In the 1950s, 9 out of 10 people recruited into the Air Force needed 8 fillings the day they arrived at boot camp, and 2 in 10 needed dentures because they were missing so many teeth. It was very typical at the time for a 13-year-old to already have lost an adult tooth because of cavities. And that's pretty amazing considering they would likely have had a maximum of 8 teeth, adult teeth, by the time they were 13. And those adult teeth would have only been in their mouth for anywhere from 1 to 6 years. So something very different than what we experience today. This was a major problem that made life very difficult and very different than today. Fortunately, there were some really smart folks looking at how to try and improve this situation. Dr. Frederick McKay moved out to Colorado and noticed in his patients that many had some brown staining on their teeth, which, while it didn't look great, had some kind of protective effect on their teeth. His patients weren't missing teeth like all of his prior patients out east. So he provided information to Dr. Trenley Dean in the federal government's health department, and they soon figured out that fluoride in the water was causing that staining in the teeth. Dr. Dean began a study in over 250 cities across the United States to see exactly how much fluoride in the water resulted in this tooth staining. And after completing some of his research, others reviewing his data found secondary benefits from that fluoride. They confirmed that while it was causing that staining, it did indeed reduce cavities. They were able to create mathematical trend lines to predict exactly how much fluoride in the water would reduce cavities and also minimize any unsightly tooth staining. Armed with that information, the health department got the National Research Council to approve studies in 4 cities on the safety and effectiveness of adjusting fluoride levels in public water systems. After just a few years, the cities where community water fluoridation um, was being tested had 40 to 60% fewer cavities than the cities against whom they were tested, the control studies. So remember those recruiting figures from the military earlier? And you'll get a feel for how astounding this progress was. If you were running the study today and got such dramatic results, you could not ethically even continue on because you would be not denying those in the control cities such a tremendous benefit. In a similar manner, many states and organizations began to lobby and petition the government for approval to begin community water fluoridation for routine use. So from 1950 to 1951, these major organizations came out and provided their unequivocal support for adjusting fluoride levels in public water systems to improve oral health. And that's exactly what community water fluoridation is: adjusting the amount of fluoride in drinking water to an optimal level to prevent cavities. That's our narrow definition on the CDC's website. But I want you also to remember the why behind that. Preventing cavities from forming keeps people of all ages from having pain, from having crumbling and rotten teeth, and from the possibility of more serious complications like infection and unfortunately, even death at times. Preventing cavities keeps kids in school instead of having to leave for treatment, which means they do better overall and they can go farther in life with that education. It keeps mom and dad in work instead of having to take time off to get to the dentist office and back. It keeps money in your pocket to spend on other things instead of having to do fillings or even more expensive care, or to have to increase taxes to cover more Medicaid bills to fix cavities of others. And that money in your pocket is usually spent on services and purchases, which put tax dollars back into your communities to pave roads and bike lanes, to update parks and community art centers, to hire teachers and firefighters, and to make your community a good place to live in, which increases your home values. Um, it is a benefit to everyone that's on a public water system, regardless of age or education or income level. Everyone gets the same water delivered to their home and benefits the same from this cavities prevention measure. It's been so effective that we hold it up as one of the 10 achievements of the last of the last century in public health. When we were talking earlier about the story of the recruits from the 1940s and the 1950s, did any of you identify with that story, as in what's going on in your life? I would guess that you generally can't, and that's a good thing. It's a good thing because that means we really have made some progress and things are better today. And that's due in part to community water fluoridation. Now, I've used the word adjusting when I talk about the definition of community water fluoridation. It's the adjusting of the amount of fluoride in water. And that's because fluoride is found naturally occurring in all water sources. Surface water typically contains 0.2 milligrams or less of fluoride per liter, coming primarily from precipitation, pulling fluoride out of the air, rocks, and soil. Groundwater has a lot more variation as it's more subject to the soil and the rock types through which it flows to become groundwater. But it typically ranges from 0.1 milligrams to 5 milligrams of fluoride per liter of water. And our oceans also contain higher amounts, usually 0.8 milligrams to 1.4 milligrams of fluoride per liter of water. So we're adjusting the levels of fluoride already found in water when we introduce community water fluoridation. We're typically taking that natural amount and adding more to reach that recommended level or optimal level of 0.7 milligrams of fluoride per liter of water. Now, where did that 0.7 milligrams per liter level come from? I previously mentioned all of that research on tooth staining and fluoride levels and how researchers could provide mathematical trend lines to predict exactly how much fluoride in the water would reduce cavities and also minimize any unsightly tooth staining. Connecting all of those dots resulted in a sweet spot of about 1 milligram of fluoride per liter water that was the target for community water fluoridation beginning back in 1945. With time, we began to question if everyone in the US drank the same amount of water. And we opened up that sweet spot to an optimal range instead and suggested that communities shoot for 0.7 to 1.2 milligrams of fluoride per liter of water, depending on where they were located. Hotter areas where people drank more could go with lower levels of fluoride, and the opposite for colder areas. Everything was geared toward this from a national public health measure with the sole goal of preventing cavities. But in 1974, the Safe Drinking Water Act was passed, which changed the focus of recommendations about water production from health benefits to harm avoidance or safety. Instead of suggesting what should be in the water, we were now focused on what had to be in water to make sure it was safe and would have no harmful effects. Because the addition of fluoride to water systems was a health measure and not a safety measure, the EPA got rid of managing this function. And with the government's medical advisor, the Surgeon General, that function was moved over to the CDC. So I'm going to describe exactly what we now do with community water fluoridation at CDC and what we do not do. First, the 1974 Safe Drinking Water Act made water fluoridation oversight the responsibility of individual states. So we at CDC primarily coordinate with individual states on what they are doing with community water fluoridation. Our focus is strictly on providing support to states on how they can best undertake community water fluoridation to achieve maximum health benefits doing so. Our goal is not, I repeat, not regulatory in any way. We provide guidance and recommendations only. The regulatory aspect of community water fluoridation stays with the EPA and states. The EPA really wants to know whenever state water systems are not properly managing their community water fluoridation efforts and exceed regulatory maximum contamination levels in drinking water. Again, their focus is on safety and not public health, but we'll talk about that a bit when we're discussing those regulatory levels. The EPA and states are primarily concerned with these regulatory levels listed here, especially those that primarily apply to water systems with higher levels of naturally occurring fluoride or rare instances of accidental overfeed. These regulatory levels include a maximum contaminant level, or MCL, and a secondary maximum contaminant level. These are the legal thresholds limits that are allowed in public water systems under the Safe Drinking Water Act. For fluoride, this MCL and goal are set at 4 milligrams of fluoride per liter of water in order to prevent bone disease and tooth discoloration. Both of these conditions are forms of fluorosis, a condition that occurs when ingesting too much fluoride. The secondary maximum contaminant level is a non-enforceable guidance value that was issued by the EPA focused on the aesthetic properties of water or the cosmetic effects to teeth which may occur. For fluoride, this level is set at 2 milligrams of fluoride per liter of water for the chance of mild tooth discoloration that may occur. So these regulatory levels are set by the EPA in contrast with the public health recommendations designed to reduce cavities, which are, again, non-enforceable and are set at 0.7 milligrams of fluoride per liter of water today. Regardless of which level you look at, know that the EPA, states, and the US Public Health Service and the CDC are in lockstep in assisting communities to pursue water fluoridation at these lower levels. That 0.7 milligrams of fluoride per liter of water level is an updated recommendation from 2015. It's the level at which there's a balance between protecting against cavities and limiting the risk of getting tooth staining or dental fluorosis. Avoiding fluorosis particularly matters to children, as your permanent or adult teeth are formed roughly by the time you turn 8 years old. But this recommendation applies to all age groups to make sure there is minimal risk of fluorosis. The recommendation update also acknowledged that fluoride is now available to people through lots of other sources. You're obviously aware of fluoride in your toothpaste, maybe your mouth rinse, if you use that, and in fluoride varnish that you get when you go to the dentist. But there's also fluoride in food products that were prepared or produced by manufacturers with facilities that use water in communities where there is water fluoridation. Also from farms that irrigate with water where fluoride levels are adjusted. The amount of fluoride we get on a daily basis has changed with the increase of these sources. And so we've seen that the number of children with fluorosis tooth stains has also been increasing. The updated recommendation took this new research on fluorosis staining into account. It also looked at research on drinking water habits amongst people across the United States. You remember from earlier slides that the recommendation had previously been a range that was dependent upon temperature. New research shows that with the spread of air conditioning and improved insulation in buildings, people don't really alter their drinking habits too much with changes in the ambient air temperature. And so the updated recommendation went with just a single number, 0.7 milligrams of fluoride per liter of water instead of a range. Simple and easier to implement. So as a presenter from the CDC, let's talk a bit about why I'm addressing you at all. What do we do in the Division of Oral Health with respect to community water fluoridation? With these focus areas, you can probably guess that community water fluoridation falls into that prevention category. We are trying to prevent cavities from forming. Again, a reminder about why. Avoiding cavities prevents pain, keeps people at work and school, lowers family costs and tax bills, and instead drives that money back into our communities. In a nutshell, we do these things that help promote healthy behaviors and provide benefits to entire communities, more than just individuals. That community designation in the term community water fluoridation really speaks to that. Specifically, we are constantly looking at the coverage and the quality of community water fluoridation across the United States. We also train water operators and dental professionals about how to implement and benefit from community water fluoridation. Some states need help doing this because funding for oral health measures is inadequate for the test. So we help to provide funding to those states. And finally, we try to monitor research and update recommendations to provide all of the resources that you need to make your community water fluoridation efforts successful. This is really an important work. For monitoring the coverage and the quality of community water fluoridation, we rely heavily on our data system, the Water Fluoridation Reporting System, or WAFERS. We'll cover this in a bit more detail soon, but on a simple level, states who are interested in doing so share with us operational reporting data for water fluoridation. And from that, we derive statistics and recommendations for getting the greatest benefit out of community water fluoridation. Some of the data reported to WAFERS are also displayed for the general public to view on our website, My Water's Fluoride. For those who prefer it, we also provide those data in map and table formats using oral health data. For training water operators and dental professionals, we created an online course in 2019, which is totally free for anyone to access and to use. We have about 500 people complete the course each year, and it's available for everybody, and again, free. We've had 13 states follow your example and decide that granting continuing education credit to water operators who complete the course is a good idea. Only one state currently grants continuing education credit to dental providers, but we're in the middle of getting that certified nationally. So all states would be able to have the same benefit. The online course is broken up into 4 sections, as you can see here. We've really tried to cover all the bases so you can feel confident and competent in initiating and maintaining community water fluoridation in your system. You should develop a good understanding of why we do it and how it works, along with all the regulatory and oversight organizations that will be working with you to deliver optimally fluoridated water to your communities. You should end up with a good technical understanding of community water fluoridation, what equipment is required to implement fluoridation and how that's maintained, some of the design considerations in implementing additives that are available, usage rates to deliver the maximum benefit to your system users of those additives, safety measures, and laboratory testing. A new addition to our training options from late 2020 is the Fluoridation Resources online course. Um, it too is a free course, but this one is non-credit. It's untimed. It's designed to be a lasting resource for everyone, but especially water operators and fluoridation program managers who might want to go back and reference some of the training on a continuing basis. If you don't need continuing education credits, this is definitely my recommendation to access this course. You can get all the details you need without having to worry about completion dates, certificates, saved trainings, resetting things, any of that. Just bookmark this one for future reference. We covered monitoring community water fluoridation coverage and quality and also training. So let's talk a little bit about direct assistance to states that I previously mentioned. CDC provides grants to states, which they can use for equipment, training, data collection and reporting, and other requirements. The goal of the funding is to try and increase the number of people with access to community water fluoridation. Connecticut is one of 4 New England states that gets this funding. That ends in August of this year, 2024, but a new round will begin again the next month in September, and states are applying for that grant right now. Finally, we try to monitor research and update recommendations and to provide all the resources that you need to make your community water fluoridation efforts successful. On the research side, we look at all of the major research databases every week for anything newly published on any aspect of community water fluoridation. We catalog that research in our own database, whether it's animal studies or human studies. For those which are of particular interest, we have a network of subject matter experts that we have review these studies. They use a standardized form in their reviews to make sure that we cover every angle of a study, the quality of the study, the findings, how applicable it is, etc. Finally, we review our database routinely, and we look for gaps in our knowledge and understanding of community water fluoridation, both on the safety and the effectiveness side. And when we find any gaps, we work to partner with other government and private research organizations to have them fund studies that help us to fill some of these gaps. Armed with that constantly improving research, we update our recommendations on the effectiveness and safety of community water fluoridation, and we do that routinely. We state that based on our current understanding and knowledge, at recommended levels of 0.7 milligrams of fluoride per liter of water, community water fluoridation is effective in reducing cavities and does not have adverse health effects in the population. It is for this effectiveness, again, that we consider community water fluoridation as one of the greatest public health achievements in recent history. I'm going to change gears a bit and get into the weeds to discuss our data collection systems, because that's where your actions are most easily translated into the success of community water fluoridation and how it is assessed for effectiveness. We already mentioned these before, but I'm going to add a little bit more by way of details. Wafers, it's our web-based tool for collecting operational fluoride data. We essentially provide a shell or a collection for states to enter their data. States enter that when they're able to do so and constantly report to us any changes or updates to the data, sometimes going back even for several years when that paperwork shows up in the management office there at the state level. It's every state's data, and we cannot do anything but make sure it's in the proper format for storage in the database. So we're not changing or altering that data ourselves. For those states like Connecticut who share their data, we can't thank you enough. Thank you, thank you, thank you. in wafers, we have included the nearly 50,000 community water systems in the US, whether they adjust fluoride levels, whether they purchase fluoridated water as a consecutive system, or whether they just maintain their natural fluoride levels. Updating data for these systems, once again, is strictly voluntary. The exception to that is for states that get CDC funding so that we can evaluate our funding to see what sort of impact we're having on spending money for community water fluoridation to improve the public's oral health. Again, thank you for sharing that and putting that in. If you really want to get into details of how wafers works, this diagram provides a little bit more clarification. We do interface with the state drinking water information system, but we can't update CIDWIS through data entry in wafers. It's just strictly a one-way direction for that data. We get mostly informational data from CIDWIS about water systems, such as the counties they serve, the populations that they serve, the points of contact for water systems, etc. For states using wafers, they have a few responsibilities. First, they need to actually provide or put in their data. We can't reach out and pull that from individual state systems. So those monthly operational reports with fluoride levels are crucial. And that's what I was saying. Thank you for putting that in and having those ready and available in a timely manner. We generally let states do that when it's most convenient for them, but we do have some timelines that drive data collection at certain times of year. And during those times, states have a responsibility to make sure data is correct. This includes updating what water systems are operating within states, system populations served, and consecutive relationships. Wafers and the information and reports that we derive from wafers are only as good as the quality of the data that states provide. The quality of this data is so important for creating our recommendations and for recognition at national, state, and local levels. Recognition on the national level occurs because the federal government has set a goal of increasing to 77.1% the proportion of people whose water systems are providing optimal levels of fluoride per liter of water. We use the data collected in wafers on the population receiving community water fluoridation to chart our progress toward achieving this national goal. At the state and local levels, for the recognition purposes, we use data entered into wafers to give out a few awards. First, states are recognized for providing data and reaching 90% of their population with optimally fluoridated water. For individual water systems, those that document meeting optimal levels for 12 months are awarded with CDC quality awards. These are mailed out at the end of the year and frequently are displayed in water utilities offices, oftentimes for several years running. This is an example of what those quality awards look like. Finally, as I mentioned, a portion of the data that's reported in wafers is boiled down to a more digestible format for the general public and displayed in the website My Water's Fluoride. States select whether to display information here and how much information is visible. We currently have 40 states that are participating. An example of what this looks like for a water system in Connecticut is here on the next screen. It provides anyone searching for their home county water systems a list of all those systems providing water for the county and indicates whether they are adjusting to that optimal recommended level or not. It lets those who access My Water's Fluoride see the system's water source and the population served. It also provides them with contact information for that water system. And I sure appreciate the Metropolitan District Commission for letting me use them as an example here. Let's see. That's it. That's really what I had to cover for today. I appreciate being able to take some of your time to talk about community water fluoridation and what that potentially means to you. I hope that the vast majority of you who are operating a system which currently adjusts fluoride levels come away with a greater appreciation for what you're doing to help benefit your communities. If you're operating a system not currently adjusting fluoride levels, I hope you've learned something about the benefits of this measure and will have an open mind ready to provide your expert views on the matter if members of your community decide to consider this to prevent cavities. And if you're at the state level, I hope you recognize your vital role in sharing your data with us and felt appreciated for the important role you play in developing guidance and recommendations for the entire nation, and really in measuring our progress toward helping people to have a healthy mouth and a healthy body. Should any of you have additional questions or ideas about how to improve wafers and our data systems, um, I would ask you to please reach out by email at any time. You can use the address that is listed here on this slide, wafers@cdc.gov. Either I or one of my colleagues who specializes in the system are more than happy at that time to go ahead and provide any assistance that we can on that matter. And just know that I look forward to hearing from each and every one of you. So again, that concludes my presentation for today, and thank you very much.